Анимеш, говорите ли вы по-русски?
Нет, я только говорю по-английски.
Жалко, тогда запишем интервью по-английски. Hi everybody, this is us again from the Union TB and Lung Health Conference. I am Denis Godlevsky and we are continuing the series of the interviews with community experts, leaders in TB field, in the field of HIV, in the field of public health. And today we have a very special guest, Animeš Singha, who is the advisor for MSF on clinical issues related with TB, hepatitis C, and HIV. Am I saying it right?
Absolutely right. So I am an advisor for HIV, TB, and hepatitis with MSF.
Yeah, and thank you for your time. Thank you for talking to us.
You're welcome.
Can you tell us a little bit about your work, about your experience with MSF, and how it is related to the Eastern Europe and Central Asian region?
So I've been working with MSF for more than 12 years now, and most of this time I've been working in the Eastern European and Central Asian region. I have worked in Uzbekistan, in the Chechen Republic within Russian Federation, and in Belarus for the majority of the time in projects which are working with patients who have drug-resistant forms of tuberculosis.
When was it? Like how many years ago or just recently?
Yeah, so in 2013, I went to Uzbekistan for a while, and then I went to Chechnya. I was in Chechnya for almost 4 years, and then I was in Belarus for almost 3 and 4 years in Minsk, where we worked on different new studies for better treatments for tuberculosis.
I want to ask you a question. How was this, both in terms of Chechnya and Belarus? But first I have to ask you, are you planning to come back?
I will see. I can never say no to anything.
Yeah, but really, seriously, how was
I think
that?
it was very interesting. I think our work in Chechnya, we had a project in Chechnya which no longer exists. The project is closed, but we had a project which was supporting the national or the Republican Center there, which was treating tuberculosis in managing patients with tuberculosis. So we were giving technical support in ensuring that these patients get the best treatment possible, especially patients with drug-resistant tuberculosis, to introduce newer drugs such as bedaquiline and delaminate. So we were able to ensure that patients in Chechnya can get access to these drugs as early as 2014. So
Wow.
Chechnya was one of the first places in the world which was able to roll out the use of these new drugs, bedaquiline and delaminate, and that we did in support with the TB program in Chechnya.
And this is interesting in so many ways because, like, I was there in Russia as well, obviously during this time, and it was not a really widely spoken thing about, like, was it intentionally or was it just something that routine for you that?
For us, it was kind of routine, I would say. I mean, wherever we work in TB projects, we try to ensure that patients can get the best treatment, the best diagnosis, the best support, and the best management possible. And Chechnya was no exception. Wherever we were seeing patients who had drug-resistant tuberculosis who were not responding to the currently available drugs. So we had to make sure that they got the best drugs so that their chances of cure was high. And these new drugs actually opened up the chances for many patients to stay alive. Many patients survived because we were able to roll out these new drugs and they had a successful treatment outcome just because of the availability of these drugs.
How many patients did you have in the program, roughly, if you can recall?
As far as I can recall, there were over 100 patients at least when I was there who were initiated on treatment with these new drugs when I was there.
Yeah.
After I left, again, there were more patients who were initiated. So I think overall, over around 200 patients were initiated on treatment with new drugs in Chechnya with the support of TB program.
Yeah, this is really cool. And with the experience in countries like Uzbekistan, like Central Asia, and also the Caucasus region, the real Caucasus, what were striking you in terms of cultural things? Is it any different from any other parts of the world? Like, were the things, anything like specific to you that comes to mind?
Not really. People are nice everywhere. I think anywhere you go, you try to you try to connect with people. You find that people are generally nice. People want the same thing everywhere. People want to stay healthy. People want to, if they get sick, they want a cure for that illness. It's a universal thing everywhere in the world. People are nice, people are welcoming. So that's what I have experienced, at least wherever I have gone to.
Your work, was it mainly related to like directly treating patients, or was it working with decision makers, public health authorities? What was the scope of it?
I think when I was working in Russia or in Belarus, it was a mix of both. So when I was working in Chechnya, it was working very closely with the doctors who were treating the patients, hand in hand pretty much with them, to ensure that the new treatments, we train them on how to use these new drugs. We support them in terms of patient management. We had counselors who were counseling the patients, so talking to patients on a daily basis, health educators and health promoters who were giving health education to the patients, their family members, because once you get TB, patients are very worried. Oh, will I infect my children? Will I infect my father who's an elderly? Oh, my mother has got this disability. Is she more prone to the disease? So there are many questions that patients have once they're diagnosed with tuberculosis, and we have a team of people, support people. There are psychosocial counselors, there are social workers who work with patients, their family members, their close relatives, to ensure that they get all the information, they get the support they need to be able not just to start the treatment, but also to continue the treatment. Treatment of tuberculosis is not like any other infection that you get. If you get a throat infection, you take antibiotic for a week and you are okay. With TB, you take 4 antibiotics for 6 months to get cured. And 6 months is not a short time.
Of course.
So you have to have that support to be able to continue and complete that 6 months of treatment.
That was my other questions, because even till now, the countries of, let's say, former Soviet Union, they tend to have this long time of inpatient treatment in the hospital, right? So the patients are being held, basically sometimes mandatory, in hospitals for months, and as opposed to the approach of DS, sorry, when people get the treatment with direct observation. So what were the models that you have implemented in those various countries of Eastern Europe, and how you were able, if you were, to switch from this in-hospital treatment to the outpatient treatment?
Yeah, so in different countries, it has worked slightly differently. For example, in Uzbekistan, we were able to start ambulatory day one, which basically means that the first day the patient is taking treatment, that treatment is at home. And we were able to do it because of a prolonged work with the other healthcare providers, engaging patients, engaging communities. But I think we have to take it also from the other side, that not everybody is eligible or wants to take treatment at home. There might be certain patients who might be afraid of being at home, or might not have the conditions at home to be able to take the treatment at home. But of course, there will be people who do not want to stay in hospital for 6 months to take their treatment. They have work to do, or they have certain social responsibilities which they have to take care of, which they can't do if they're in the hospital. So I think it has to be more patient-centered, assess the needs of that individual patient, and tailor your support based on that patient's need. It should not be one size fits all. It should be an individualized approach. If a patient wants to stay in the hospital because he's afraid he's got a young child at home and he might infect the child, well, of course, you should be able to provide that support to stay in the hospital. If the patient has got a social commitment, if he's taking care of his parents or somebody else and wants to be at home, why not? If it is medically allowed, basically meaning that the patient is not sick enough to stay at home.
Let's look at it from the other side. In the developed countries, there is like a tendency that the time for the patient inside the hospital should not be very long, right? Maybe I'm getting it wrong, but that was my perception for many years. So do you think, like currently, what's the situation in other countries of the world, in developed countries, maybe in other countries that you have worked? Are we able to deliver this type of patient-centered care across the globe yet, or not?
Not universally, and not in all countries, and that too not to all extent. So it varies country to country. For example, countries are trying to change the system of how it is done. Some countries are doing it as a pilot to see whether that works or not. Because, for example, it is more linked to health financing, how your health services are financed. And in certain countries, health services are financed based on bed occupancy rate, which means that if your beds are not occupied in your hospital will not get that funding. So you have to keep your beds occupied in the hospital to be able to get funds to run the hospital.
Yes.
So it's more complicated than just changing your practice. You have to also change the financing model and other things around it. I think Belarus did a trial, a modeling study and a pilot of showing that, okay, if you transition from a hospital-based care to a home-based care, wherein patients stay at home, take their treatment at home, and come and collect their medication, and the observation of treatment, what you were mentioning is directly observed treatment, can be done either by a family member, or another innovative approach that they did in Belarus is video observed treatment. So they launched this VOT, wherein patients have got this app on their phone, wherein the time they take their drugs, they record a video, and that video is sent to the nurse who's supposed to observe it, and the nurse can observe it on her system and mark that yes, the patient was able to take the drugs today. So video observed treatment is a digital adherence tool, what we call it. And there are other digital adherence tools coming up, but this is one of the ways which is more patient-centered. It saves time. For example, even if you are staying half an hour away from the hospital, that's half an hour going to the hospital, half an hour coming back, and another 1 hour spent in the hospital to wait, take the drugs, wait a bit to see if you have any side effects or not, and then go. That's 2 hours gone of your daily activity. So how are you going to go to work, or if you are studying, or if you have other role responsibilities, how are you going to do that? So video observed treatment saves all that. You can do it in 2 minutes. You just start your video, take your drugs, and within 2 minutes you're done. But as I said before, this is not one size fits all. Some patients might be too weak to stay at home, or might have some medical conditions which might require closer monitoring, so they have to be in a hospital. But most patients, I think, would benefit from being at home and taking drugs with some sort of support to be able to, but at least there should be a mechanism where they can report that if they have side effects, if they have nausea or vomiting after taking drugs, they should be able to go back to the hospital and report that, yeah, I needed more support.
From the countries that you have seen personally and that you see on the global scale with your experience, with this particular aspect of, let's call it like linking the patient-centered care with the public health approach and trying to merge them, which countries are doing better globally, in your opinion, and specifically in the region?
So globally, I don't think I have the answer to the global question, but in the region, I think different countries are taking different initiatives. Belarus, for example, where I have worked for quite a while. So my experience is mostly Belarus and Uzbekistan and Russia. So I can tell you a bit about these countries. Belarus, for example, is taking a lot of effort in ensuring that patients can get access to the new patient-centered approaches. For example, Belarus recently did an intervention with MSF support, wherein it looked at how patients who have alcohol use disorders and tuberculosis, how to best support those patients to be able to complete their treatment. Because in a study in Belarus, it was found that a majority of patients who were unable to complete their treatment had alcohol use disorder. So if you have TB and you have some sort of alcohol use disorder, then it is more likely that you will not be able to complete your treatment because of certain issues. And Belarus, what it did was it ran a pilot project wherein it provided patient-centered care for those people, harm reduction activities, psychiatrist intervention, and other substitution therapies. And these patients were able to complete their treatment as well as patients who did not have alcohol use disorder. So they did this pilot, and now they're implementing the results of this pilot on a more broader scale to ensure that other patients can also benefit from it. I think there are different learnings we have from different countries, and I think it is very easy to share that experience and try to adopt those models in other countries as well. So yeah, different countries are doing different things, but I think we need to have a platform where these things can be shared between the countries. MSF has this platform. We used to or actually we still, this year we had this TB symposium for Eastern Europe and Central Asia. This year we had the 10th one in Tajikistan, in Dushanbe, wherein we had leaders and experts from all these countries gather together and share experience that, oh, this is the challenge within our country, this is what we did, and these were the successes and the failures of our approach. And every country was sharing the highlights of what they were doing. And this is an activity we've been doing for quite a while, which is a sharing platform.
Do you feel like this conference where we are at the moment is playing as such a platform, or what is your perception of the conference so far?
I think it is a very good platform for learning about what's new in the field of tuberculosis. It's a good platform for networking, wherein you get to meet the experts, talk to experts, share your concerns and ask them questions. So I've heard this, but we are concerned in our country. This is a special thing. We have this problem. Will it work in our country? And to do the networking and get the kind of resources that you're looking for, I think this is a very good platform for it. But this is not the one solution fits all. Not everybody will get all their answers.
Yeah.
So you'll have to follow it up within your country. You'll have to find experts who can come and support your country if you need certain kind of support, that is, or who are present in the region who can then help you implement certain things or give you the knowledge or the tools for yourself to implement.
What was the most interesting part scientifically for you so far at this event?
So you must have seen MSF was doing another clinical trial called the NTB clinical trial.
Of course.
Last year we had shared the results of our TB practical clinical trial, and this year we were sharing the results of our NTB trial. What this offers is more choices for patients with drug-resistant tuberculosis, more choices which are shorter than the previous treatments. And by previous treatments, I mean the 18 months to 2 years treatments that we had previously. It offers oral choices, which basically means that you don't have to take injections anymore. So now you don't only have the 6-month BPAL and BPAL-M regimens, but you also have these NTB regimens which can be offered in different circumstances for patients. So you have more options for patients with MDR-TB, and all of these options are oral options. There's high chance of treatment success with these options and lower toxicity with these options as compared to the older regimens. So that's a very interesting and very exciting. So we are living in very exciting times for MDR-TB.
Yeah, I agree.
For MDR-TB, since the onset of first treatment in the 1980s, there has hardly been any movement till 2011 when we first saw these bedaquiline and delaminate come in. Till then, there was nothing in MDR-TB. We were just using some drugs which somebody had made up, and there was not very good rigorous scientific evidence, and those combinations led to very poor outcomes. Only about half of the patients were cured, and huge side effects. You have seen so many activists who have got hearing loss.
Absolutely, absolutely.
So these were terrible regimens, and since 2011 we have been making progress, and we should continue to make progress, because this is a disease which, despite existing for over 40 years, very little has been done.
I cannot skip this question because you were in Russia, and also since we are talking about the novel treatments, and bedaquiline appeared in 2011, approximately at the same time, and probably when you were in the region. In Russia, there appeared a drug. I won't be able to tell the international non-patented name, but it was called perclazone. Have you heard of it? Why didn't it fly internationally, in your opinion? Because I know that in Russia it's still being used, and I'm not sure about other countries, but I know for sure that in Russia it's still there.
Yeah, I am aware of this compound. However, I don't think I have been able to read up much on this, so I think it is something I should probably do. I'm not sure if it has actually been data from the use of this compound has actually been presented to the international community for the purpose of registering it, because once a new compound is discovered, how it works is you present it to the international community and say that, look, this is how we found this, but I'm not sure if it has been presented within. So I think that is probably the step which is missing. And when it comes to use within Russia, I think it is within the Russian guidelines which are currently in use, but I think it is not among the standard regimen to give. It is one of the choices in case you can't make up a standard regimen. The standard regimen that is there within the Russian guideline, I think, still includes piraquilin and linezolid and a fluoroquinolone. So those drugs are still there, but I think perclazone is there among the list which can be used, but it's not compulsory to use that drug as far as I know. I might be mistaken.
Of course, NTB sets up the whole new tone, like a new step for better treatment uptakes, better levels of people being cured from TB. But this is always related to the issue of access and pricing for the medications. And when it comes to pricing in our region particularly, and by the way, I'm very interested if you have personally witnessed it, we see patients not trusting to generic manufacturers, sometimes a lot, and saying that like, oh, we're not sure who is making this drug. And even doctors. Have you faced it?
Personally, I have not faced this either from patients or from healthcare providers, skepticism about the quality of generic medication. I think there are certain systems in place to ensure quality, and one of them is the WHO pre-qualification. So I think once a certain molecule is out of patent, other manufacturers can come in and start manufacturing generic versions of that molecule, and that brings the price down.
Of course.
And that is a good thing.
Drastically.
Let me say it is a good thing both for the state, both for the countries who are the healthcare providers, and for the patients, because it brings down the cost of treatment. It ensures that more patients can get that better treatment, and it reduces the state budget that you would spend on treating patients. So it's good both for healthcare providers and for patients. The only thing you have to be careful about is that the generic manufacturer that you are getting your drugs from has got some sort of a quality process, is on a pre-qualification list, and adequate quality controls exist to ensure that whatever you are getting has been checked to ensure that the active compound is there.
But pre-qualification is a voluntary process, so companies have to apply themselves and they have to flag to WHO, we want to get pre-qualified, and it's a long process, it's not happening fast. So what would be your advice to the communities in case they negotiate with their local manufacturers who are trying to come up with generic versions of various molecules? What would be the advocacy advice in terms of convincing them to pre-qualify?
I think this is slightly beyond my expertise, but I can give you my 2 cents on this.
Absolutely.
I think the manufacturers have got an incentive, and we have to. I think most manufacturers know they have an incentive in getting their drugs pre-qualified, meaning that they can then supply it through the global drug facility. So it can be listed on the GDF catalog, and then you can enter the market through GDF, and it's beneficial for them. You have access to a bigger market. So pre-qualification is beneficial for the manufacturer, and then it also brings in confidence of the countries that if you are pre-qualified, countries have that confidence that they can procure your product, and it is of that quality that is needed.
To close the interview, like people who are watching this and who are following the news from the conference, they might get a little bit of contradictory messages, because on one hand, the NTB trial results, the shorter regimens, and it looks like an exciting news, and it looks like we're getting there. On the other hand, at the opening ceremony and with activist protests, but also with the messages of the keynote speakers, we hear things like there are more cases of TB revealed than previously. There is a lack of funding. There is like a serious gap in getting there to end TB. What is your perception at the moment? Are we getting there? Is it getting better, or is it not enough, or is it getting worse? So how do you feel about that?
We were making progress before the COVID set in, and 2 years of COVID has actually pushed us behind on all the progress that we made. Since the 2022 data that has been released in the Global TB report of 2023 has shown that some of that reversal that happened, we are able to make some more progress now. So we have started making progress. Increasing the number of patients who have been diagnosed is actually a good thing. We previously had over 10 million people estimated to fall ill with TB, out of which only about 6.7 million or so we were able to diagnose. And this year it is over 7 million we are able to diagnose. So the number of missing people has reduced. And that is what we want. We want to diagnose not just 7 million, we want to diagnose all those 10.6 million. And only after you diagnose all those people that you will be able to treat all those people. And then if you treat all those people, you will reduce that chain of transmission of infection and ensure that all the people who are diagnosed or who have TB and are left undiagnosed, they don't die or they don't continue to suffer and to transmit. So that's a good thing I see. Activists raising their voice, I think, is a very important thing. Because without activism, we will not be able to make progress in many things, such as rolling out better treatments for people. Activists were asking for better treatments for people, and that I think is a thing they should continue, and we all should continue to push for. We now have, after so many years in MDR-TB, we have a 6-month all oral regimen with only 3 or 4 drugs in the regimen. And to this date, of the all the people who have MDR-TB in the world, around 417,000 people who were likely to have MDR-TB. How many of those people were able to access this regimen? Couple of thousand. That's nothing.
That's nothing.
So unless everybody who deserves better treatment gets that treatment, we have to continue to raise our voices. And not just activists, all of us should be activists. If one patient cannot get the best treatment, every patient should be able to get the best treatment that they have for their cure. Nobody should get a bad treatment.
I don't think that there is a better message to close our interview, and I think this is the message for all of us, that we have a lot of work to do, and the guys, activists who are watching us, please make sure you keep going and we keep going. Animesh, thank you so much for your time. Really appreciate it.
Thank you.